Here we're going to be looking at examples of vulvar dysplasia progressing to squamous cell carcinoma. So this first case we're going to start off with is a case of low-grade squamous intraepithelial lesion of the vulva. And you can see that this is a very large and exophytic process. So you can see the stroma here, and then you can see this large growth coming off of the surface. And this is actually what we would see in a condyloma. And so if we go down and we look at closer magnification, you will see that we have features of a low-grade lesion. Mainly that would be the cholecytosis that we see here. And so if you look at this lesion, you'll notice that you do have very nice perinuclear halos. You have the racinoid cells, meaning that the nuclei are kind of irregularly shaped and darker. In addition, you have a papillary growth pattern, which you can see here. So you see this fibrovascular core with a blood vessel coming up and making a little papillary horn. This is what you see in exophytic condylomas, usually more associated with HPV-6 or HPV-11 infection. And so, and here's another one, and you can see this kind of spire coming off, and this is what gives the wart its velvety external appearance. So this would be a low-grade squamous intraepithelial lesion, probably due to a low-risk HPV infection. And then actually in this field, we can see a little bit of binucleation. So binucleation doesn't have to be frequent. It's just a helpful finding sometimes in dealing with a low-grade lesion. So that's a low-grade lesion. At the other end of the spectrum, we have this. Turn the slide over for you. Alright, so here we have normal vulvar squamous epithelium, well, relatively normal, and you can see that the basal layer is maintained in the bottom half. There is a little bit of hyperkeratosis indicating that there's been some irritation, and as we move closer to the lesion, we'll notice that the basal layer starts to get way more purple at low power, and this is because there's much more nuclear crowding in this area. You'll notice that there's still a little bit of maturation at the top, and if we come over here and we take a closer look, this is a great example of a lesion progressing to high-grade dysplasia. So you can see here that the base is getting much more crowded, that the nuclei are much more atypical, meaning that they're different in size and shape. This guy's really big, some of these guys are small, some of these really big guys are getting up towards the top, which is loss of maturation. And you can see here, just right next door, that the entire thickness of the epithelium has been replaced by these primitive basaloid cells. So this would be a high-grade lesion in contrast to the low-grade lesion we just saw. Notice that there is probably not any identifiable binucleation, and that the cytoplasm has shrunk considerably, leading to crowding of the nuclei. Now, if we continue right next door, you have this big pushing tumor, and so this would be a cut showing something that we would call invasion or squamous cell carcinoma. A lot of times a funny cut of the surface or a fold of skin can actually lead to this, so we have to see actual invasion of the tumor, and you can see where I've marked this slide with a dotting pin. And right here at the base of this, so you have the dysplasia here, you have a small nest of very bright pink cells, which is something we often see when tumor cells invade. They become very bright pink. So these cells have invaded into the stroma along with these, and so this is just the very earliest invasion of squamous cell carcinoma into the stroma in this vulva. So this is the opposite end of the spectrum from the low-grade lesion we saw. This is a high-grade squamous intraepithelial lesion with a very small focus of invasive carcinoma within it.